Okay, now we're going to transition from aortic aneurysm to aortic dissection. Now, over the years doing this, I've noticed that people often use aortic dissection and aortic aneurysm interchangeably. Now, aortic dissection can certainly coexist with aortic aneurysm, but understand they are not the same thing. So let's illustrate that now. Here we have the intima, the media, and the adventitia, and we have the blood flowing through the normal lumen of the aorta. Well, somehow, for some reason, there is a tear in the intima. And as the blood is rushing by, it starts to dissect between the intima and the adventitia. And you get this intimal flap that is waving in the flowing blood because the intimal layer has been dissected off the tunica media. This is an aortic dissection. Notice that the aortic diameter, however, is normal. Now, with regards to ultrasound evaluation for aortic dissection, we can certainly rule the diagnosis in, but you can see here that the sensitivity is only 67 to 80%. So you certainly cannot rule out the diagnosis. And as you'll see again here later, if you clinically think the patient has aortic dissection and the ultrasound is normal, you have to continue the workup with some other imaging modality. So this is what a aortic dissection looks like on ultrasound. Here we have the spine, the inferior vena cava, and this is the aorta at the level of the SMA takeoff. And you can see this small flap, this intimal flap that is dissected off of the wall of the aorta and flapping as the blood flows by. Now here's the corresponding CAT scan image for the same patient. You can see this aortic dissection here. Here is the same patient with the video clip, that with each beat, there is an oscillation of that intimal flap as the blood rushes by. And you can see actually this intimal flap is dissecting up into the superior mesenteric artery. Here's another one. You can see initially that the aorta looks fairly normal, but as we slide down, there is the SMA. We see an intimal flap right here. Now take note, the aortic diameter is normal in appearance. Also, hopefully you're thinking to yourself that this would be quite easy to miss. And in fact, it is quite easy to miss an aortic dissection on ultrasound. As we mentioned briefly a moment ago, the sensitivity is quite poor, and this is a reason that I was saying that if you clinically think the patient has this diagnosis, you have to advance to other imaging modalities. Here's another case. This is a aorta in long axis, and you can see an intimal flap right here, oscillating as the blood is flowing by. This is again consistent with aortic dissection. Now bear in mind, the management of aortic dissection depends on the origin of that aortic dissection. If the aortic dissection originates from the ascending aorta, then this is a surgical disease. However, if the aortic dissection originates from the descending aorta, then by and large, it's usually a medical management disease. This is, of course, assuming that the dissection doesn't involve any major organs or the patient is not unstable. Now, with ultrasound, you can evaluate the thoracic aorta to some degree. Now, in this case, you can see the aortic outflow tract, the aortic valve, and the aortic root with the ascending thoracic aorta. You can also see a small portion of the descending thoracic aorta here. So if you have a patient who has an aortic dissection, you could start off with a parasternal long axis view of the heart and look to see if you can see any clear intimal flaps. If you see a intimal flap here, then you know that this is a type A aortic dissection, an aortic dissection that is going to require surgical management. Another way that you can evaluate for ascending aorta involvement of aortic dissection is to actually measure the ascending aorta. This is what we've done here. You'll get your parasternal long axis view of the heart, and you'll freeze the frame with the aortic valve leaflets open, and you'll measure across the ascending aorta as seen here. And the normal diameter is less than 3.6 centimeters. Anything over that is consistent with a dilated ascending thoracic aorta, If the patient has a confirmed aortic dissection at another location, say the descending thoracic aorta or the abdominal aorta, then this would be highly concerning for concomitant involvement of the ascending thoracic aorta. Now, a dilated aortic root greater than 3.6 centimeters certainly does not confirm the diagnosis of aortic dissection. It could also just be an aortic aneurysm involving the ascending aorta. Now, another way that you can evaluate the ascending aorta as well as the aortic arch is to try the suprasternal aortic arch view. And this video and image was supplied courtesy of Dr. Hampton. You can see here we've taken the cardiac probe or phase array probe. It's been placed in the jugular notch with the probe indicator pointing away from your point of view to the patient's left scapula. The back side of the probe is fanned towards the patient's chin, and you should see the aortic arch as seen here. Here is the ascending aorta, aortic arch, descending thoracic aorta. This is just for point of reference, the right pulmonary artery. And we can see right here the brachiocephalic artery, the left common carotid artery, and the left subclavian artery. And you could take a look here and look for any intimal flaps that are coming through this area. When you're trying to acquire this view, it's often helpful to put a shoulder roll in between the patient's shoulder blades to displace the chest in an anterior direction. Now, as I mentioned, the management depends on the origin of the dissection. And we can evaluate the pericardium, the aortic root, and aortic arch to see if there's any ascending aortic involvement. The reason I mentioned the pericardium is because if the aortic dissection does come back and involve the aortic root, sometimes you'll get seepage of blood into the pericardium that can go on to develop pericardial tamponade. If this patient isn't rapidly repaired, then certainly death is imminent. In fact, these patients have a very high mortality rate. But regardless, you can look for subtle clues of aortic dissection involving the ascending aorta by evaluating the pericardium. As I previously mentioned, most of the time you're going to have to advance to CT or transesophageal echo or TE. And most of the time you're going to do this because, again, management critically depends upon its origin as well as what organs the aortic dissection involves, and the vascular surgeon needs to make plans on how they're actually going to repair the aorta. So most of the time you're going to be getting advanced imaging of these cases. Another limitation of ultrasound evaluation for aortic dissection is it's very difficult to tell acute versus chronic. I myself have seen a couple of patients who present with chest pain. We do a bedside ultrasound and discover an intimal flap consistent with dissection, but it later turns out that this was actually chronic and the patient didn't know it. So it can be quite difficult to tell the difference between acute and chronic aortic dissection. So overall, bedside ultrasound for aortic dissection has value. If you see a flap, they likely have the diagnosis. You can go ahead and initiate the management before definitive testing. But again, most of the time, you're going to ultimately be getting advanced imaging. And the biggest take-home point of all with point-of-care ultrasound for the evaluation of aortic dissection is do not use ultrasound to rule out aortic dissection. Clinically think they have the diagnosis, you have to get advanced imaging, usually CT angiogram. So I hope you enjoyed the talk on ultrasound evaluation for abdominal aortic dissection. If you have any questions, I can be reached at this email here.